Good morning and welcome to my very first webinar. I appreciate all of you attending as we start to present information about the MMPI-2-RF Spine Surgery Candidate Interpretive Report and the Spinal Cord Stimulator Candidate Interpretive Report. Just a couple of disclosures. I have received research funding from the University of Minnesota Press for many of the studies cited in this presentation, and as a co-author of the MMPI-2-RF Spine Candidate Interpretive Report and Spinal Cord Stimulator Candidate Interpretive Reports, I receive royalties on the sales of those reports. Just a little bit about the participants. We're hoping that all the participants today have experience, at least some experience with presurgical psychological evaluation of spine surgery candidates, and that they have experience with the use of the MMPI-2-RF. If you don't have that experience with the MMPI-2-RF, I would strongly encourage you to attend a webinar on the general MMPI-2-RF information. Today we'll be talking about two different types of spine surgeries and their respective reports. First is the Spine Surgery Candidate Interpretive Report, and of course with spine surgery the goal is to repair or mitigate the physical condition underlying the patient's pain in order to reduce the pain and improve the patient's ability to function. There are three major types of spine surgeries that we've examined, although this report applies to other spine surgeries that are not listed here. Laminectomy discectomy is the first of those, and that involves removal of a herniated portion of an intervertebral disc, and it may also require removal of a portion of the vertebra in order to gain access to the disc. The second major type of spine surgery is spinal fusion. That involves removal of a disc and replacement of the disc with a material that solidifies to fuse together adjacent vertebrae while restoring normal disc height, and that may involve implantation of hardware to stabilize the fusion. And then the third is artificial disc replacement. This is a growing area and involves removal of the disc and replacement with a device that both restores normal disc height and allows for movement of that joint. The second type of surgery we're going to be applying to today is spinal cord stimulation. This has a different goal. The goal of spinal cord stimulation is to reduce perceived pain and improve the patient's ability to function without addressing any underlying cause of pain. In spinal cord stimulation, leads containing electrodes are implanted into the epidural space along the spinal cord, and these electrodes deliver stimulation along ascending nerve pathways, thereby reducing pain. Stimulation involves a two-step process. First, there's a trial that's 3 to 7 days, which involves implantation of the electrodes with an external stimulator device. During that time, the best stimulation pattern is determined. And if that trial results in 50% or greater reduction in pain, then the device is permanently implanted. If not, then the leads are removed. So on today's agenda, we will begin with just a brief discussion of psychosocial factors impacting spine surgery results based on previous versions of the MMPI. Then we'll give a couple examples of studies using the MMPI-2-RF in spine surgery and spinal cord stimulator candidates. The bulk of the talk will be spent examining the components of the Spine Surgery Candidate Interpretive Report and the Stimulator Candidate Interpretive Report. We'll then present a case example where we will give a little bit more of the features of these reports and conclude with a question and answer period. So spine surgery is not always effective in reducing pain and improving function, even if the pathology underlying the pain is corrected. For example, with discectomy, a recent analysis of insurance claims on 494 discectomy patients found that 28% had unfavorable outcome, and 80% of those patients went on to have additional surgery. Similarly, with spinal fusion, a recent study using 4 measures of health-related quality of life found that 47 to 61% of patients showed significant improvement on any one of the 4 measures, and only 27% showed significant improvement on all 4 of the measures. Once the patient has had back surgery and it fails, the consequences can be pretty significant. The majority of these patients never return to work. They can become angry and depressed. Iatrogenic problems, those problems that result from the treatment itself, can develop. The financial disincentives to recovery can increase. The total cost of the case will rise dramatically. The potential for drug addiction becomes stronger. And often patients go on to have additional surgery or spinal cord stimulation. In fact, for spinal cord stimulation, the major indication is failed spine surgery syndrome. But there are other indications for spinal cord stimulation too. Many of these patients have very complex spine problems where the consequences of having that surgery, the costs of it may not be worth the benefits. And so then spinal cord stimulation may be an option there. And also patients who have complex regional pain syndrome or RSD or other conditions not amenable to spine surgery are often candidates for spinal cord stimulation. And again, the results are variable. In a recent study showed that 64% of patients received the permanent spinal cord stimulator implant received greater than 50% reduction in pain, despite having significant improvement during the trial. And the cost of spinal cord stimulation can be quite high. It's greater than $52,000 in the first 24 months post-implant, according to this Hollingsworth study. A growing body of research, which most of the participants are probably aware, shows that psychosocial factors are associated with reduced effectiveness of both spine surgery and spinal cord stimulation. This slide shows the number of studies that have used the MMPI or MMPI-2, looking at the outcome of spine surgery, and the scales that have been found to be associated with reduced outcome. And you can see most frequently scales 1 and 3, the HS and HY scales, have been found to be associated with reduced outcome, but also the depression scale, scale 2, as well as PT and PD, which assess, among other things, anxiety and anger. So we've gone on, based on a lot of these initial studies using the MMPI and the MMPI-2, to apply these to the MMPI-2-RF and looking at spine surgery and spinal cord stimulator candidates. And I just want to point out, as an aside, some of the key differences between the MMPI-2-RF and the MMPI-2. One of the main differences is that the RF significantly reduces the shared variance between the clinical scales of the MMPI-2 and captures that shared variance in one new scale called demoralization, or RCD. After removing the shared variance, then the restructured clinical scales capture the core constructs of the MMPI-2 clinical scales. And the other major difference is that the MMPI-2-RF is significantly shorter, 338 items rather than 567 items, which is a big advantage when you're working with back pain patients whose sitting tolerance may not be as great as other patient populations. The MMPI-2-RF contains 51 scales, 9 validity scales, 3 higher order scales, 9 restructured clinical scales. Then there are 23 specific problem scales composed of 5 somatic cognitive scales, 9 internalizing scales, 4 externalizing, 5 interpersonal scales, 2 interest scales, which we don't look at in this report, and the 5 Psi-5 scales. So talk a little bit about this study where we looked at psychosocial factors increasing the risk for poor spine surgery results. We followed 344 patients in this study with an average follow-up of 142 days post-op. These are the fusion types, surgery types, mostly fusion patients with some disc replacement and laminectomy discectomy patients, and then a smattering of other types of surgeries. And not included in this study were 41 patients who had fair to poor or poor prognosis based on our evaluation and didn't go on to have surgery. So we're only looking here at patients who had surgery and looking at the way in which the MMPI-2-RF was associated with outcomes. The outcome measures that we looked at were pain rating on a 0 to 10 scale, the Oswestry Disability Index, a measure of negative affect, which combined Likert ratings of depression, anxiety, fear, and worry, and patient satisfaction with the outcome on a 0 to 10 scale, with the scales reversed so that higher scores represented greater dissatisfaction. And for all measures except for satisfaction, the baseline measure was used as a covariate. And here you can see correlations of some of the MMPI-2-RF scales with the 4 outcome measures. The demoralization scale, RCD, was strongly associated with all 4 of the outcome measures, especially negative affect. The somatic complaint scale, RC1, whoops, that one went in the wrong place, was also strongly associated with all the outcome measures, as well as RC2. Malaise, another strongly associated scale, self-doubt, and especially the negative emotionality scale from the Psi-5 dimension. All of them had strong correlations with reduced outcome, both in terms of less pain reduction, less functional improvement on the Oswestry, more negative affect, and poorer satisfaction with surgical results. Another study that we did looking not at spine surgery but at spinal cord stimulation outcome involved 319 subjects, mean age of 53 years, average time to follow up here was 146 days. And similar results were seen, although some of the scales had less of a strong relationship and others had a stronger relationship than with spine surgery. Again, RCD was strongly associated with all 4 of the outcome measures. You can see that the somatic complaint scale, though, RC1, was only strongly associated with poor reduction in pain and poorer satisfaction. RC7 was actually more strongly associated with this results of the spinal cord stimulator than it was with spine surgery. A new scale shows up here, and that is inefficacy, which has a strong relationship, and again, stress, worry, and the negative emotionality scales from the Psi-5 are strong predictors of reduced outcome across the 4 outcome measures. Another way to look at these results is to consider the relative risk ratio, that is, the extent to which an elevated score on any scale raises the risk for poor outcome on a particular measure. So here we're looking at the Oswestry scale post-op, where we consider poor outcome of a score of 40 or greater. And so what you can see, so for example, for scale RCD, the demoralization scale, if the patient scores a T-score of 60 or greater, that raises the relative risk of getting a poor outcome 1.42 times, so that if a patient scores above a T-score of 60, they have a 79% chance of having a poor outcome on the Oswestry scale. If they don't score at 40 or greater, their risk is 55.8%. The 3 scales on this particular slide here that look at Oswestry show that the malaise, cognitive complaint scale, and the negative emotionality scales all have relative risk ratios of 1.61 or greater. And for example, the negative emotionality scale, if the patient scores above a T-score of 65, then their chances of having a poor outcome on the Oswestry scale are 92.9%. If they score at less than 65, it's 57%. I just want to summarize the scales in our studies that have been found to be most strongly correlated with reduced spine surgery and spinal cord stimulator outcome. These include RCD, the demoralization scale, which captures general unhappiness and dissatisfaction. RC1, the somatic complaint scale, which examines diffuse physical health complaints. RC2, the low positive emotion scale, that is lack of positive emotional responsiveness. And RC7, the dysfunctional negative emotion scale, which describes maladaptive anger, anxiety, and irritability. Those are the RC scales that are most strongly correlated with reduced results. Then we have the specific scales and the Psi-5 scales most strongly correlated with reduced outcome, and these include malaise, which is an overall sense of physical debilitation and poor health, self-doubt, which examines lack of self-confidence and uselessness, the inefficacy scale, the belief that one is indecisive and inefficacious, the stress-worry scale, preoccupation with disappointments and difficulty with time pressure, the anxiety scale, which is pervasive anxiety, frights, and nightmares, the family problem scale, which describes conflictual family relationships, and the negative emotionality, neuroticism, revised scale from Psi-5, which examines anxiety, insecurity, worry, and fear. So having reviewed a little bit of the research, we'll now go on to talk about the spine surgery candidate interpretive report and the spinal cord stimulator candidate interpretive report, describing some of the components of those reports. The first thing to note about these reports is they provide all of the information of the general MMPI-2-RF interpretive report. So if you've used the clinical interpretive report before, you'll get all the information that's involved in those reports, plus you get the information specific to either spine surgery or spinal cord stimulator candidates, depending on which report you're using. So we'll talk about the report structure a little bit. Some of this will be familiar from the general clinical report, and some of it specific to our candidate groups. The first thing you'll see will be the patient profile, and in the patient profile, depending on which report you've chosen, the comparison group will be automatically chosen for you. So if you are evaluating a patient who is a female spine surgery candidate, what you'll see will be the mean and standard deviation on the scale for that group, for the female spine surgery candidates. And then you'll be able to easily tell where the patient falls compared to the comparison group. So you can see on scale EID here that this candidate shows a significant elevation and significantly above the comparison group. If you go down to the bottom on the profile page, you can see that the patient's that the population comparison group population mean score is 51 and standard deviation is 11, which is displayed graphically up here. But the other interesting thing here is you can see that 90% of patients in the female spine surgery candidate group would score at or below the level that this particular patient is scoring. This next slide gives you the number of patients that make up each of the comparison groups. So for the spine surgery candidates, there are 662 women, 590 men, and for the spinal cord stimulator candidates, there are 336 women and 218 men. The next thing you'll see in the report will be the scores by domain. This provides T-scores for all the scales in the report, and scores that are interpreted in the report are listed in bold. So if you look on this slide, you can see that, for example, the anxiety scale, AXY, is shown in bold. So on that report, you'll see that the AXY scale is interpreted, whereas the stress-worry scale, the T-score is 47. It's not in bold, so that scale will not be interpreted in the report. The next thing you'll see in the report is the intended use statement, which says that The qualifications of the user is that he should have experience with evaluation of surgical candidates and with the MMPI-2-RF. And the context of the evaluation will need to be considered, and I'm going to be talking a lot about that towards the end of this report. Also, it indicates that annotation for each statement in the report is indicated by a superscript tied to endnotes in the reference section. One of the things that's unique about these MMPI-2-RF reports, not just this, but the general report and the other reports that have been developed, is that for each statement, it's accompanied by a superscript. If you roll over that superscript, you can see the reference for it, and that makes the reporting completely transparent. The next thing that you'll see in the report is the synopsis of the results. And that synopsis will give any validity concerns. It will also tell you comparison group findings, how this patient stacked up to its specific comparison group, and any presurgical psychological risk factors that were identified in the report. The next three sections of the report compare the patient to the general normative MMPI-2-RF sample, not the spine surgery or spinal cord stimulator comparison group. And this is from the general report, and this gives information about protocol validity, any substantive scale interpretations, as well as diagnostic considerations. Then we go on to the parts of the report that are specific to the type of candidate you're looking at. So we're comparing, the first part of this would be comparison group findings. And this is a set of construct-based statements which are based on the scale item content. The clinical implications of any elevated scores are given, as well as clinical implications of uncommonly high scores. So, for example, if the patient showed an elevation on scale RC2, a statement would come out like this: she reports a comparatively low level of positive emotional experiences for a spine surgery candidate. Only 9.5% of comparison group members convey this or a lower level of positive emotions. The next component of the report are the presurgical psychological risk factors, and these I consider the core of the report. This is a description of the presurgical correlates of test taker scores associated with reduced outcome. It's divided into 9 domains relevant to the outcome of spine surgery and spinal cord stimulation, and the statements in this presurgical psychological risk factor part of the report are fully annotated and linked to empirical studies. So, for example, one of the dimensions that we're going to talk about in a minute is the fear avoidance dimension, and the clinical correlate that we looked at is the fear avoidance behavior questionnaire in this particular dimension. So here are the 9 risk factor domains or dimensions. The first is depression and demoralization problems. These are unhappiness and life dissatisfaction issues. The second are pain and somatic sensitivity problems. This is heightened awareness of physical problems, especially pain. The next are pain coping problems. Those are maladaptive behaviors and cognitions that accompany the patient's pain. The fourth domain is health orientation and medical adherence problems. This is a tendency to resist therapeutic recommendations. The fifth are anxiety and stress problems. These are stressful events and chronic anxiety that may impact the patient's healing process. The next domain is fear avoidance problems. These are behaviors and thoughts resulting from fear of pain or damage. The seventh area is interpersonal problems. These are behaviors that limit the ability to draw on support systems. The eighth area is substance abuse problems. These are inappropriate use of drugs or alcohol. And the ninth area are recovery disincentive problems. These are issues such as reinforcement of disability and excessive pain behavior. The next component of our report are the spine surgery outcome correlates. And these are narrative description of specific areas of reduced surgical outcome that have been found to be empirically linked to MMPI-2-RF elevations obtained in the patient's profile. including areas such as poorer pain reduction, poorer improvement in functional ability, greater levels of medication use, worse emotional state, poorer return to work rate, and others. The next component in the report are follow-up recommendations. These are general treatment guidelines designed to reinforce surgical outcomes or to be alternative to surgery based on any major MMPI-2-RF elevations. These may include things like antidepressant medication, pain management training such as biofeedback or hypnotherapy, cognitive behavioral techniques, techniques to assess or test motivation, or consideration of a chronic pain program, as well as other recommendations. The next component of the report is item-level information. From the general interpretive report, the item-level information will include unscorable responses, critical responses, and user-designated item-level information. And from our specific spine surgery or spinal cord stimulator candidate reports, there are what we call critical follow-up items. And we developed these follow-up items by conducting a survey of 10 psychologists who are highly experienced in presurgical psychological screening. They read every item in the MMPI-2-RF, identified those items that they felt were critical in evaluating a surgical candidate, and then from that list of questions, we developed a set that we considered to be important in examining the patient and for follow-up purposes. And this section is going to be very critical for you who are using a report to look at closely because it identifies specific issues that you might want to talk to the patient about. The next components of the report are the annotation and reference sections. And again, each statement in the report is annotated and referenced, and the references are updated on a regular basis as more research is developed. Again, you can roll over a superscript in any part of the report to see the reference associated with it. So each of these components that we've talked about so far, I'm going to illustrate now with a specific patient, Ms. E, and her report is available. If you signed up for this webinar, you should be able to access the Ms. E's interpretive report. Ms. E is a 56-year-old candidate for spine surgery. She's been married twice, currently for 3 years. She was injured on the job as a nursing assistant. She's been in pain for 26 months, and it's low back and left leg pain. She hasn't had any previous spine surgery. She's been unable to work for 8 months. She has a history of arrest for shoplifting in the distant past. She's a candidate for an anterior lumbar interbody fusion at L4-5 and L5S on the 2-level spinal fusion. And so now we'll go on to a profile, and the first thing you'll see are the validity scales. These will be familiar to everybody who's used the RF, and you can see that there are no major validity concerns here, no significant elevations on any of the scales. Next, we go on to the higher order and restructured clinical scales. Here you can see clearly that compared to the female spine surgery candidates, this patient shows elevations on the EID scale, the demoralization scale, RC2, and RC4. You can see at the bottom again what percent of patients score at or below the level scored by this patient. Here we have the somatic cognitive scales and the internalizing scales. Here, 2 elevations are clearly seen. Then we go on to the next set of scales, the externalizing interpersonal and interest scales. And I want to point out here, using this slide, a unique feature of the spine surgery and spinal cord stimulator candidates reports. If you look at scale JCP here, the T-score is 63, so that places the patient below the normal cutoff of 65. However, if you look down at the bottom, you'll see the patient has a score that is only in the top 5 percentile of patients who are female spine surgery candidates. So even though the T-score is below 65, the patient scores well above one standard deviation above the mean for this patient population. So in our report, this scale will be interpreted. And here you can see on a disconstraint scale of the Psi-5, the patient scores well above the patient population. So that's the profile page. The next thing you'll get will be a synopsis. And the synopsis will state that this is a valid profile. It'll give you just a general overview of the comparison group findings, which point to possible concerns about cognitive complaints, emotional problems, including unhappiness and dissatisfaction, inefficacy, a low level of positive emotions and anger, odd perceptions and beliefs, and behavior problems, including irresponsible behavior and substance use. And then it identifies possible presurgical risk factors, including demoralization and depression, pain and somatic sensitivity, pain coping, health orientation, and medical adherence, fear avoidance, interpersonal problems, and the substance abuse domains. Then you'll go on to comparison group findings, and I'm not going to read this whole slide, but I'm just going to give you an example by looking at the emotional internalizing problems. Here it says the patient reports a comparatively large number of emotional problems for a spine surgery candidate. Only 11.9% of patients, comparison group members, convey this or a greater level of emotional difficulties. And here you'll see a superscript, which in a second I'll show you how this works. More specifically, she reports a relatively high level of unhappiness and dissatisfaction for this population. Only 7.3% of comparison group members convey this or a greater level of morale. In particular, she reports a comparatively high level of inefficacious decision-making for a spine surgery candidate. Only 16.3% of comparison group members convey this or a greater level of perceived inefficacy. So in the next slide, you'll see what these superscripts do. They're all tied to endnotes. When you see a superscript, you can go to the endnotes page, and the endnotes page will tell you what kind of statement is being used in making that particular sentence. So there are three types of statements we make in our report. There are statements based on a test response, that is an elevated score on a particular scale. There are statements based on clinical correlates, and those elevations then are tied to specific empirical references. And here are all the references that the statement is tied to on a clinical correlate. And then the third type of statement is an inference statement. Here on this inference statement here, score on the anger proneness scale of 66 triggered that inference statement, and the inference statement is a statement based on the judgment of the report authors, that is myself and Yossi Ben-Porah. So there are these three types of statements listed in the endnotes. The endnotes, again, just to summarize, when there's a clinical correlate statement, those are tied to references, and we'll see that in a second. So just here are some more comparison group findings. There are too many to put on one slide. And then we go on to the 9 risk factor domains. Here you can see a number of domains where the patient risk factors are identified. So in the demoralization and depression domain, we can see that compared to other spine surgery candidates, this patient is more likely to be experiencing depressive affect and to have a low energy level and to feel exhausted. And similarly with pain and somatic sensitivity problems, compared with other spine surgery candidates, this patient is more likely to perceive herself as deserving and needing assistance from others. She's also likely to report greater functional disability associated with pain. So you can see here on the next page the research reference list. So the way you would access that would be by looking at the superscript see what end note that's tied to, and then the end note will give you the specific references. And it wouldn't be unusual in a profile or a profile that has a number of elevations, multiple elevations. You may see as many as 100 references associated with that particular report. And here are some more of the presurgical risk factors that are seen in this particular patient: the fear avoidance problems, interpersonal problems, and substance abuse problems. Also, I want to point out here that if there are no risk factors associated with a particular domain, those are just listed at the end of the presurgical psychological risk factors section. Then we go on to the post-surgical outcomes part of the report, and we can see that based on the scale elevations this patient has shown, we can expect her to be likely to report higher levels of pain, greater levels of disability, experience more negative affect and higher levels of psychological distress, be more likely to take Schedule II opioid medication, to be less likely to return to work, to have lower levels of satisfaction with surgery, to convey stronger feelings that the surgery did not meet expectations, and to report a more negative overall outcome if you compare this patient to other female spine surgery candidates. Then we have a set of treatment recommendations based on the elevations seen in the profile. So I'll just give you a few of these. So for example, on the patients showed an elevation on scale RCD. The recommendation here would be that the patient is significantly demoralized, feels overwhelmed, and may be quite dissatisfied with life circumstances. She may have difficulty becoming motivated and following treatment recommendations. Helping the patient to recognize positive aspects of her situation and focusing on each improvement, however small, may help the patient build momentum for recovery. Similarly, based on the scale elevation on scale RC2, we can say the patient is also experiencing depressive affect, which can impact surgical outcome. Consideration should be given to antidepressant medication, which may also help with pain reduction, as depression can increase pain awareness, including individual psychotherapy, and the overall surgical treatment plan may help the patient identify and experience pleasurable activities while rehabilitating. So each one of these treatment recommendations, again, is tied to a specific scale elevation. The next section I'm just going to review through you are these items for follow-up. Again, these are the items based on the survey of the 10 experienced psychologists. And these can be important for follow-up. And in this webinar, we're not getting the content of the items in order to protect the integrity of the test. But if you will look at the sample report associated with this webinar, those items are printed out for you. And the way this works is, for example, item 23 is one of the critical items. Again, in the report, I'll tell you the statement that is associated with item 23. It shows you what direction the item was answered. In this case, the patient answered it true. Only 16.5% of patients in this comparison group answered this question is true. And it also shows you the scales from the MMPI-2-RF that contain that item. So KR, RC7, AGG, and the negative emotionality scale. So we've gone through now the components of the report and a sample report, and I just want to make a few final comments. First off, the MMPI-2-RF is the only broadband psychometric test having an empirical base. That is, the spine surgery candidate interpretive report and the spinal cord stimulator candidate interpretive reports are the only reports in which the test itself is tied to the outcome of spine surgery or spinal cord stimulation. Other tests have not been validated by looking at the outcome and its association with the test. This allows for the most accurate estimate of the extent to which psychosocial factors are likely to impact the outcome of spinal cord stimulation and spine surgery, and we can then tie treatment recommendations to to specific identified risk factors. The critical items for follow-up examine issues that you should be following up with on the patient. Some individuals who do presurgical screening don't like to have the MMPI available for them when they do the diagnostic interview, in which case you might have to call the patient or have the patient return for a follow-up visit to look at these follow-up items. In other cases, if you have the MMPI available to you prior to the interview, then you can follow up on those items during the interview itself. Also, very importantly, the spine surgery candidate interpretive report and the stimulator candidate interpretive report provide the objective cornerstone for a comprehensive presurgical evaluation, which definitely should include a diagnostic interview, a review of medical records, psychometric testing, any of it in addition to the MMPI-2-RF, and then a comprehensive report integrating all information. In other words, this is not, the reports are not considered to be standalone reports, not something you should be basing a decision on without doing these other components of the evaluation. And so I will open it up for questions or any discussion. Thank you for listening, and I look forward to your questions here.
Good morning, Dr. Block. This is Deb. How are you?
Good.
Good. Thanks so much for that overview. We do have several questions for you. For folks who have not yet typed a question into the chat box, if you do have one, we welcome you to do that. We'll address as many questions as we have time for.
Okay.
We'll start with, there's a question here about how this MMPI-2-RF report might correlate with or associate with your scale on the MBMD, the one related to the block algorithm.
Algorithm, yes. Yeah.
Yeah, can you speak to
okay,
that
well,
a little bit?
First up, I can tell you that they use the block algorithm. They cite that on the MBMD as well as the BHI-2. There's a couple points that I want to make about that. First off, as I pointed out during the talk, the MBMD and the BHI-2, neither one of them have been empirically validated against the outcome of procedure. What they've done is, in both of those reports, as I believe they've done, is correlate their data with my presurgical psychological screening algorithm, which I didn't talk about in this particular presentation. The other thing that I want to point out is that if you remember in the very end of my talk, I said that this report is only one component of a comprehensive evaluation that should include medical records review as well as a diagnostic interview. And my algorithm that I developed incorporates all three of those components. I don't think that it is, in my opinion, doing justice to an evaluation to take one component of that, just the diagnostic test, and correlate it with my algorithm. So I hope that answers your question.
I think that might go to the, we've got a lot of questions here just about, other tests and, corresponding data points. So in your opinion, this question is asking, do these interpretive reports that you just went over supersede the use of your presurgical psych algorithms?
No, they are part of it. They give you the tools you need to be able to provide objective documentation of the risk factors and treatment recommendations, but you definitely need to consider the context of the evaluation because the type of surgery the patient's going to have, the things that you know about incentives from talking to the patient, those will all color the way that you use these statements. You've got statements that are are given in the report. Some people will want to just use them verbatim if you know that they are consistent with what you found in the other aspects of the evaluation. But if you don't find that there's consistency, then you might want to modify those statements.
Okay, question here about additional supplemental tests that you might recommend to measure things such as catastrophizing, et cetera.
Yeah, well, there's a whole host of those things that we have used in the clinical correlates. The fear avoidance questionnaire or the Tampa scale of kinesiophobia, those are excellent measures of fear avoidance, and we found in other studies that those correlate with outcome. I use a thing called the demoralization scale a lot. It's a British test that is a different way of looking at demoralization, and we found that to be associated with reduced outcome. I often use a cognitive coping scale. Usually I use the coping strategies questionnaire as a supplemental scale. The Oswestry Disability Index is one of our outcome measures. I use that fairly commonly. I also have the patients complete a pain drawing, look at the distribution of pain compared to the underlying condition. There's a whole host of questionnaires that you could use. I think that sort of depends on user preference. The thing that I have been looking at recently is trying to assess strengths. What you'll find in the user guide for the MMPI-2-RF spine surgery candidate and spinal cord stimulator candidate interpretive reports is that this test really is used to identify risk factors, and it does not identify patient strengths. So now I've been working on things that look at patient strengths and how they might mitigate some emotional or psychosocial risk factors. And in doing that, I've been using the patient activation measure and in some ways using the coping strategies questionnaires, looking at the cognitive coping aspects of that. So you can use supplemental scales in both ways to further flesh out some of the risk factors as well as to look at some of the possible strengths that the patient might bring to the surgery.
Okay, so going back a little bit earlier in your presentation, some of these questions were posed early on. Relative to the Eldry study, what was the time post-implantation for that?
Boy, I don't really remember. I'm thinking it was 2 years. I'm not positive.
Okay. We've also got a request for the reference for that study, I believe, if it was the 2017. So if we can just, we can email that out to folks if they're interested in it. If they just
sure.
Make a note on the survey as they exit, if they want that reference, we can certainly send that to them.
Sure.
Okay.
Sure.
Can you talk a little bit about the spine surgery candidate comparison group and if it's comprised of successful outcomes?
If it's comprised of, well, I mean, it's got both successful and unsuccessful outcome. The average reduction in pain on the spine surgery candidate group, if I'm remembering correctly, was about 3 points on a 10-point scale, 2.5 to 3 points on a 10-point scale. But it varies a lot depending on the level of risk factors and other factors. For example, we published a study which is in the reference section on workers' comp and found that patients who were covered by workers' comp had significantly less reduction in pain and less improvement in function on the Oswestry. The Oswestry, overall, I think the average reduction is about 20 to 25 points on a 100-point scale. But again, it varies a lot depending on the level of risk factors seen.
Okay, so another question about just outcomes. clarification, I guess, is being asked whether or not people have a greater than 50% chance of poor outcome even if there's no elevation on a particular scale.
I think you're referring to that one.
About the question. Yeah.
I think what you're referring to, the question is referring to is that one slide on relative risk ratios, and and that's what the data would say, that on that one one dimension of the Oswestry dimension that's examined on that slide. Yeah, the patients overall, even if they score lower, would still have a greater than 50% chance of not getting a reduction below 40 on an Oswestry scale. So on that one dimension, yeah, they would not be expected to have great outcome.
Okay, a couple of questions here that I'm going to sort of ask together because they're both about validity scales. How would you handle profiles that suggest a high degree of underreporting? And then related to that, what validity scales and scores are being used to verify protocol validity?
Well, they're all being used to verify the protocol. All the validity scales are being used to verify protocol validity. And what scales are? Ask me the first part of that question again.
Yeah, so it was a separate question. How do you handle profiles that suggest a high degree of underreporting?
Well, again, this is where the context becomes very important. And you will get patients who have a high degree of underreporting. That means that you usually see on those patients, a high L or to a lesser extent a high K, but the high L patients. And then you have to consider, the typical things that you have to consider when you see a high L. One of them being, patients' education level and religious preferences. A lot of times people don't want to admit to faults. And then sometimes when patients have a high score on L, you'll see a pattern that's less than the typical comparison group elevations, but you have to then kind of use your judgment to say, is this profile particularly characterize the patient's performance or not? This is where clinical judgment becomes very important. Just as with over-reporting, it becomes important. You can't just separate with any test the test results from the overall comprehensive interview, medical records review, and report itself. You have to really take that into account. And if you find a patient who's underreporting, say why that's occurring. And if you've been able to look at the MMPI beforehand, you can then explore with the patient what are the bases. You can talk to the patient about the fact that they seem to be not reporting any of the emotional distress that you might find in a diagnostic interview, and why is that? Do they not want to? Do they feel as though if they report anything, they will not be a good surgical candidate? A lot of times patients will tell you that they think that they can't tell you what's going on in their lives, or you're going to say, you have too many risk factors. I'm going to tell the surgeon to wait, or that you need treatment before you go on to have surgery. So it's definitely worth discussing and with the patient if you get a sense when you're interviewing them, or get a sense from the profile of underreporting, that you talk with them about the reasons for that and what the actual feelings might be.
Yeah, so some additional questions about, over-reporting, under-reporting, and I just want to mention to folks that I did include in the chat box, if you haven't seen it yet, there is an offer, a promotional offer for folks who would like a free trial of both of these reports and access to the user's guide for these reports. We do have a complimentary free trial where you get one of each of the different reports and the digital user's guide on Q Global. So I welcome any qualified users to go to the website landing page that I did put in the chat box and try the reports out. Also, that page contains a lot of resources. The first chapter of the user's guide is out there for free. There's a flyer out there as well as some additional sample reports, including an annotated sample report. So there is a question here, Dr. Block, about folks who feel like they're competent in use and interpretation of the MMPI-2 and 2-RF. And having read some books on pre-surgical evaluation, but not having yet actually performed these evaluations, do you have any recommendations for folks who are wanting to get into this area of practice to ensure competency?
Yeah, that's a really good question. The reason I took this whole area into consideration and started doing, writing the books and doing all the research is because there really was no uniformity and there really is no training in this area outside of clinical health psychology programs. So I think the best that you can do is maybe hook up with a colleague who does these or, attend webinars like this and then try to very gingerly approach doing these evaluations so that you don't get way out over your skis and start making conclusions without really knowing what you're doing. But I'd say if you can't get hooked up with a psychologist who does these, then I think it's going to be a matter of just kind of going slowly, maybe finding a surgeon who you can just tag along with, learn about the surgeries. When I started doing this back, 30 years ago, I actually went into some surgeries. Psychologists can't stand to do this, but you can go in and watch some of these major surgeries. It really gives you an insight into what the patient has to go through to do this and to recover from it. So, if you can get some exposure to the surgeries, talk to psychologists, who do this, do some reading, you can at least start off down this road. But there is no clinical certification at this point in pre-surgical evaluation.
All right. Well, I think that concludes the bulk of our questions. And so I want to thank you, Dr. Block, again for taking your time and offering your expertise in pre-surgical psych evaluations and use of the MMPI-2-RF.
Oh, thank you. Thank you all for attending.
Yes, thank you everybody for attending. We do have a survey upon exit. If you would give us any feedback or if you have any remaining questions, that would be the place to provide it to us. Thank you so much and have a great afternoon, everyone.
Thank you.